We've been dispatched to a residential address and found a 40-year-old male lying supine on the ground. His elderly neighbour states that she saw him up water blasting on the roof earlier today. It appears as though he's fallen 6 metres from the top of the roof down to concrete. On assessing our patient, we've found that he has an altered level of consciousness, has GCS of 5, made up of 1, 2 and 2, because he's extending and he's moaning and growing into pain. He's got a heart rate of 50, he's got a rest rate of 12 with slow irregular breaths, and he's also grunting. We've done a BGR to rule out hypoglycemia, which was 7.6, so that's within normal range, and his temperature is 37. His blood pressure is 160/90. We've done a rapid trauma sweep and found that he's got evidence of injury to his posterior aspect of his head with a crepitus and some spongy spots. So with this in mind, we're going to treat him as for TBI. Now RSI is indicated for patients with a lower GCS less than 10 and a clinically significant airway or ventilatory compromise, which he has with his grunting and his irregular rests. So we're going to call for an R50 for an RSI capable officer. We've called for them and they're 10 minutes away. So while they're en route, we're going to use our pocket CPGs and set up for RSI using the RSI checklist. So the first thing we want to do is pre-oxygenate our patient. We can do this using a non-rebreather mask at 10 litres of oxygen per minute, or we can use a bag valve mask at 10 to 15 litres per minute. I'm also going to insert an OPA to see if he tolerates it and just to keep his airway open, which he does. So the reason I'm using a bag valve mask is to assist his ventilations. I'm also using PEEP attached, and that's at 5 centimetres due to his TBI. I'm also going to set up for capnography. This needs to be attached to the monitor a little bit forward to let it calibrate. What I also want to do is I want to attach nasal prongs. These aren't going to be connected up to the oxygen just yet, but they're going to sit underneath the bag valve mask, and they're going to allow for passive oxygenation during laryngoscopy. So my offside is going to continue oxygenating my patient, and while they're doing that, I'm going to make sure that they're all set up with assessment. So I'll put the NOBP cuff on, the ECG leads are attached, and the SpO2 probe needs to go on. Once that's all done, I'm going to make sure that the monitor's where it can be seen, but I'm going to make sure that there's enough space off to here for the airway gear, off to the right side of the head. The capnography has been attached to the defibrillator, and that's all ready to go. So we've gained IV access with a 16 gauge in this arm. It's patent. We're going to gain in that arm too because we want bilateral large bore IV access. We're also priming up a bag of fluids so that we can run that through. So we're going to continue to pre-oxygenate our patient. We also want to make sure that he's in a good position for airway management. So this can involve just placing a towel or something underneath his head until we've got good alignment, which we have there. We also want to prepare by putting a Thomas tube holder underneath his neck. We're going to leave it undone, but just so that it's there for when we need it. Our suction's nearby. We've checked it and we've turned it off, waiting for in case we need it. We want to clear the area up before the officer comes so we've got good access to both sides of the patient. And we want to do another set of vitals so that we can update our RSI officer saying that he is still status 1, his GCS is still 5, and that his condition hasn't changed. We can also consider administering morphine, particularly if it becomes very competitive, but at this stage we don't need to administer that. So prior to RSI, we want to have discussion with the RSI officer about what to do in the case of failed intubation. This may be in the form of trying again with a bougie for another intubation, it may be in the form of basic airway management, or we may move to a crike. We also want to have a look just before he gets here about whether or not we can extricate and leave. We've got quite a difficult extrication at the site, so that's not really an option, and that's why we've stayed and decided to RSI where we are.